Good af Good afternoon, everyone. My name is Julie Wong. I am from the Alzheimer Society of Toronto. I would like to welcome you to our Advances in Dementia Research webinar series that is presented by the Toronto Dementia Research Alliance in partnership with the Alzheimer Society of Toronto. This series discusses recent updates in dementia research and highlights dementia research studies that are occurring all across Ontario. Today, we will have speakers that will speak about the role of biomarkers in early detection and treatment. A little bit of housekeeping. I am going to ask that everyone remain on mute so that everyone can hear clearly. You're most welcome to submit any questions or comments that you have using the chat box throughout the session, and we will get to as many as we can at the end. This session is going to be recorded and it will be posted on the Alzheimer's Society of Toronto YouTube channel, as well as the TDRA website. As such, I will ask that you refrain from posting any personal information in the chat. So I'd like to tell you a little bit about the Alzheimer's Society of Toronto if you are not familiar. The Alzheimer's Society of Toronto is one of 20 plus local Alzheimer's societies who provides information, education, and support to people living with dementia and their family and friends, healthcare professionals, and the general public. For Toronto, we service within the M postal code. Also, I wanted to let you know that we service all dementias and a diagnosis is not required to access any programs and services. Our services are offered in person as well as virtually through Zoom, as well as the ALS Educate e-learning platform. To learn more, I'd invite you to visit our website at www.alz.to and take a look at our calendar of events for upcoming offerings. I'd like to also introduce you to our partner, the TDRA. A little bit about the TDRA. Established in 2012, the Toronto Dementia Research Alliance, or TDRA, is a collaboration among the University of Toronto, Baycrest, the Centre for Addiction and Mental Health, Ontario Shores Centre for Mental Health Sciences, Sunnybrook, and the University Health Network. Together with its partners, TDRA aims to strengthen the link between basic science and clinical research to better understand, prevent, and treat dementia. So now I would like to turn it to my partner over at the TDRA, Natalie Dren, to tell you a little bit more.
Thanks, Julie. Hi, everyone, and thank you so much for joining today. If we could just move to the next slide. Great. Okay, so as part of our education and community outreach, Alzheimer's Society of Toronto and TDRA created a research studies section on the Toronto Dementia Network website. So this section lists dementia studies that are open for participation in Toronto at TDRA partner sites. All the studies that we list on that website are led by TDRA affiliated scientists. They are approved by what's called a research ethics board, and the information is explained in plain language. You can connect directly with the study teams to express interest and find out if you're eligible. There are studies for people with dementia, mild cognitive impairment, those at risk for dementia, caregivers, and healthy volunteers. So for more information, you can visit the website that is shown here in orange or use the QR code to scan and get to the website. I will also drop the website in the chat box so you can click directly. Okay. And on the website, there are two main pathways. First, you can browse for a study on your own, and when you find one you're interested in, you can fill out the contact form to be connected with the research team who will enroll you in the study if it's something that you're eligible for. Or at the bottom here in gray, if you're not sure where to start, you can fill out a questionnaire to be matched to a study, and any information you enter will be securely stored and protected. So we'll move to the next slide. Okay, and this is what the website looks like. So to find studies, you can use the search bar at the top. You can type a keyword like Alzheimer's disease and apply filters, or do both to narrow down your search. Or you can use the quick search buttons that are in the blue boxes. So if you're not sure where to start, you can fill out a questionnaire and someone will help match you to a study. And to do this, click Match Me to a Study in the orange box there, or scroll to the bottom of the page and you'll see another orange button that says Can't Find a Study You're Interested in. And both of those will take you to a questionnaire. So each study summary, as shown in the example on the right, describes what the study is about, who can participate, the location, and the time requirement. Again, all in easy to understand language. The study being discussed today is listed on the TDN website. So you will be able to read more and connect through the study team there, as well as through the presentation today. And we'll go to the next slide. Okay. Before I introduce our speakers, I just wanted to note that we will be having a question and answer period at the end of the webinar. So feel free to put your questions in the chat box as we go along, and we'll get to as many as we can at the end of the webinar. So we're grateful to be joined by two excellent speakers today. So Anjana is a clinical research coordinator and research nurse at Sunnybrook, working with Dr. Mario Masalis, who I also see here today. So welcome. On Alzheimer's and frontotemporal dementia studies. She's a registered nurse with over 8 years of experience in neurology and neurosurgery and is dedicated to compassionate, equitable care and research. And we also have Tina, who is a clinical research coordinator at Sunnybrook, also supporting dementia studies with Dr. Masalis. She brings experience from previous work in endocrine, vaccine, and obesity research, and earned her clinical research coordinator certification. And Tina is passionate about advancing effective treatments through research. So welcome to both our speakers, and we look forward to your presentation.
Thanks so much, Natalie, for the intro. So I'll go ahead and share my screen. Alrighty, so today we'll be talking about what biomarkers are, the core biomarkers of Alzheimer's disease, as well as the DIAN-2 research trial that will be starting for the primary prevention population, which will be starting at Sunnybrook soon. So I wanted to start off by talking about what dominantly inherited Alzheimer's disease is. So it is a neurodegenerative disease, which means that this disease involves a progressive loss of nerve cells or neurons in the brain or the spinal cord. And this loss of neurons leads to a decline in memory, cognition, and movement. Some other neurodegenerative diseases include Parkinson's disease, frontotemporal lobe dementia, and amyotrophic lateral sclerosis, also known as ALS. And it is a rare form of Alzheimer's disease that is inherited. So a few hundred families worldwide have these rare genes that cause this type of Alzheimer's disease. And it's a less common form of Alzheimer's compared to the late onset Alzheimer's disease, which typically develops after the age of 65. And in early onset Alzheimer's disease, it can affect individuals usually in their 40s to 50s, but in some cases, it can start as early as their 30s. And it is linked to specific genetic mutations, which we'll talk about later on, which contribute to the disease's accelerated progression. So this disease is characterized as having a more aggressive disease course than late onset Alzheimer's. And what are biomarkers? Biomarkers are measurable indicators of what is happening in the body. So they are assessments of what is happening inside the living body, shown by the results of laboratory and imaging tests. So they can be found in blood, bodily fluids such as cerebrospinal fluid or CSF, and they can also be found in organs and tissues. And in early onset Alzheimer's disease, the biomarkers studied primarily focus on identifying changes in CSF and blood, along with brain imaging techniques. And some of these changes measured include levels of proteins such as amyloid beta and tau proteins in the CSF and blood, which are the primary hallmarks of Alzheimer's disease. We know that Alzheimer's disease is characterized by the formation of these protein deposits, known as amyloid beta plaques and tau tangles, made of tau protein in the brain. And when it accumulates over time, it creates a large buildup of brain protein fragments. And this buildup is thought to slow down the person's ability to think, as well as remember, which are well-known features of Alzheimer's disease. Neurofilament light chain. It is a biomarker that measures neurodegeneration, so the progressive loss of the neurons or the nerve cells in the brain or the spinal cord, and it's associated with cognitive decline. And elevated levels of neurofilament light chain, or NFL, are associated with neuronal damage, so loss of the neurons, which leads to cognitive decline in cognitive abilities and functional abilities. And this is seen in individuals with Alzheimer's disease. And in Alzheimer's disease imaging biomarkers, an amyloid PET or a tau PET can be used to visualize the buildup of the proteins in the brain. And how a PET scan works is a radio tracer is injected into the patient's bloodstream. The tracer travels to the brain and binds to the amyloid or tau protein buildup. And then the PET scan detects the radiation emitted by the tracer, creating an image of the either the amyloid protein distribution or the tau protein distribution. And an MRI or magnetic resonance imaging, it can be used in Alzheimer's disease research and diagnosis as well, primarily to assess brain atrophy, which is when there is shrinking of the brain, and it refers to the loss of brain tissue, and specifically neurons and their connections. And this is seen in individuals with Alzheimer's disease. So I wanted to talk a little bit about the ATN criteria. ATN stands for amyloid beta, tau, and neurodegeneration. And it is basically a classification system for Alzheimer's disease. It groups individuals based on biomarkers related to amyloid, tau, and neurodegeneration. And it was developed by the National Institute of Aging and Alzheimer's Association. So it categorizes individuals based on their biomarker evidence. And it's called a research framework because it's intended to use for observational and interventional research and not in routine clinical care. And it focuses on the diagnosis of Alzheimer's disease with biomarkers in living persons. So this ATN criteria can be used to diagnose Alzheimer's disease in someone with or without symptoms. So individuals can be grouped based on their biomarker profiles, from those with no evidence of Alzheimer's disease changes in the brain, with those with all three amyloid, tau, and neurodegeneration present. And this criteria is used by researchers to study the progression of Alzheimer's disease. And it's also used to identify individuals who may benefit from early treatment or intervention. So here is two MRI images. And on the left MRI image, it is showing a 68-year-old female with Alzheimer's disease. And what this image shows is the thinning of the medial temporal lobe thickness, which is the brain region crucial for memory. And it's compared to the figure on the right, which is of a 60-year-old female control, meaning someone who does not have Alzheimer's disease. And the thinning of this region is a key feature of Alzheimer's disease, and it can be assessed using an MRI. And the two of the images show key differences, primarily in brain atrophy, which is the loss of brain tissue or the shrinking of the brain, particularly in the medial temporal lobe region, which includes the hippocampus and entorhinal cortex. And this is a prominent feature, and the location of this atrophy is what is seen in patients with Alzheimer's disease. However, in the normal control, there's some age-related atrophy, but it's generally less pronounced and distributed differently. And these are PET images obtained with an amyloid imaging agent called Pittsburgh Compound B. And it's a radio tracer used to visualize amyloid plaques in the brain. So the first image shows a normal control. And then the second, third, and fourth image shows three different patients who have mild cognitive impairment. And then the last one shows an image of someone with Alzheimer's disease or AD. Mild cognitive impairment is where someone experiences memory, thinking, and language or judgment problems that are greater than the typical age-related changes, but it's not severe enough to interfere with daily life. However, in patients who have mild cognitive impairment, some can have control-like levels of amyloid, some have intermediate levels, and some have Alzheimer's disease-like levels of amyloid. And while MCI or mild cognitive impairment can be a predictor of dementia, it's not a guaranteed progression. And many people with MCI remain stable or even improve. But I just want to show you that the PIB-PET scan is a technique primarily used to diagnose and assess the progression of Alzheimer's disease and other dementias. So why are Alzheimer's disease biomarkers important? Well, we know that the biomarkers are measurable indicators of the disease's presence, progression, and response to treatment if they are on one. Biomarkers are important for diagnosing the disease as well as understanding and managing the disease. And they allow for an earlier and more accurate diagnosis. And this enables the patients to understand their condition and potentially benefit from earlier interventions or treatments. So the biomarkers measured in the blood and CSF can identify early brain changes associated with Alzheimer's disease even before the symptoms start. So it's essential to optimize the benefits of available treatments. And this can potentially slow down the progression of the disease. And biomarkers can help monitor the disease progression over time. And it's crucial for confirming Alzheimer's disease-related changes in the brain. And this can help scientists target these changes for treatment. Biomarkers can also differentiate Alzheimer's disease from other types of dementias, such as those caused by vascular disease or Lewy body dementia. And this is crucial for the appropriate management and treatment of the disease. So now I wanted to talk about the DIAN-2 study. DIAN-2 stands for Dominantly Inherited Alzheimer's Network Trials Units. And the sponsor for the study is Washington University. That means that they will be paying to run the trial at Sunnybrook Hospital. This study is for the primary prevention population. So in recent research studies, it indicates that amyloid beta may start to build up in the brain 15 years or more before the onset of symptoms. And the study will provide a window of opportunity for intervention prior to symptom onset. For the primary prevention population, the treatments would start before any irreversible neuronal loss, so death of the neurons or the nerve cells, or symptoms of AD that occur. And it's called the primary prevention because the intervention point takes place before the amyloid plaques form in the brain. So the DIAN-2 primary prevention arm is a placebo-controlled trial, and it'll be the first of its kind, targeting amyloid deposition in individuals at risk for dominantly inherited Alzheimer's disease prior to the onset of significant amyloid beta pathology. And the study will try to determine if the treatment, which is called remternetug, which we'll talk more about later, has the potential to modify the disease, prevent or reverse the changes in the brain that are associated with the development of Alzheimer's disease symptoms. And in stage 1, it'll be a blinded study treatment period. Stage 1 will be 2 to 5 years long. And this is where remternetug, which is a treatment, will be compared against the placebo. So you'll be either assigned to remternetug or placebo, and that will be to a 1-to-1 ratio. So you'll have a 50% chance of receiving either or. And in stage 2, participants must be aware of their mutation status because they'll be receiving the treatment open label. So you won't be receiving a placebo, it'll be active treatment. And this will go on for an additional 4 years. And if you are mutation negative, meaning you do not carry one of the gene mutations associated with dominantly inherited Alzheimer's disease, you will not qualify for stage 2. And in stage 2, during the open label period, this stage allows mutation positive participants from stage 1 to be provided with active study treatment while investigating whether some of the Alzheimer's disease biomarkers may improve over time and whether remternetug will prevent or delay the symptoms of Alzheimer's disease. So in total, the study can last up to 9 years. And some of the assessments that you'd be required to complete are listed here. So MRIs, PET scan, a lumbar puncture, blood work, and cognitive testing. And the compensation would be $45 Canadian for every visit on site. And every time you complete a safety MRI, it'll also be $45 that you'll receive. And then for any baseline or annual visits, baseline means the first time when you receive the treatment, you'll be provided up to $780 Canadian. And these baseline and annual visits take about 3 to 4 days long because some of these assessments can take that long to complete. So the study will offer paid genetic testing and counseling to participants who are at direct risk of inheriting the dominantly inherited Alzheimer's disease mutation. And what genetic counseling or genetic testing is the process of looking at changes or mutations in the person's genes that are associated with dominantly inherited Alzheimer's disease. And there are 3 known gene mutations called amyloid beta precursor, presenilin 1 and presenilin 2 that cause dominantly inherited Alzheimer's disease. And the participant will be asked to complete genetic testing prior to stage 2, and that's when you'll receive remternetug open label. And the testing will be completed by obtaining a buccal, saliva, or maybe even a small blood sample from you through a kit that's sent to your home. And if you decide to be tested, a genetic counselor will coordinate the testing procedures, and they'll also interpret the test results, and they'll explain how the mutation is passed through generations in your family and your level of risk of developing the disease. So I'm gonna stop sharing my screen here because Anjana would like to share her screen. So she's going to talk about the investigational product, which is remternetug.
I'm just going to share my screen, just 1 second. All right, can everyone see my screen? Perfect. All right, thank you, Tina, for that great overview and for laying the foundation for today's discussion. So for the second part of this webinar, we'll be diving into the key terms and concepts that help frame this study, followed by a closer look at the investigational product, how it is administered, what are the typical visit looks like, and how we monitor safety throughout the trial. So let's begin with some core terminology. What are amyloid plaques? They're composed of amyloid beta, a protein that builds up in brains of people with Alzheimer's. Antibodies are protective proteins your immune system produces when exposed to a pathogen or a foreign substance. Monoclonal antibody has the same function as an antibody, but the only difference is that they're lab-created proteins that mimic the body's natural antibodies. So let's look at how the brain sends messages, focusing on the difference between a healthy brain and the one that's affected by Alzheimer's disease. So starting with the image on the left, we can see a comparison between a healthy brain over here and a brain that has Alzheimer's. So already from the beginning, in a healthy brain, neurons, or brain cells, are well connected and active. These neurons communicate with each other using electrical signals and chemicals through structures called synapses, which you can see right over here. A synapse is a small gap between two neurons, shown in the top right image right over here. I don't know if you could see if I place let me see if I can use my cursor here just to see, like right over there. So that's a synapse. So you see there is one neuron and there's another one right over here. And that's how neurons communicate. It's through the axon terminals, and the gap between this is called the synapse. So that's where the sending cell releases neurotransmitters that are then taken in from the second neuron. This process allows messages to travel quickly and smoothly across brain regions, supporting memory, thinking, and focus. Now, looking at the Alzheimer brains, we can already see there's damage. Anatomically, we can already notice that there's an atrophy in the brain. My colleague Tina already had talked about it in a previous slide, but you can see right over here, that's the difference in terms of shrinkage of the brain in a patient with Alzheimer's. Neurons are already dying, and there's already loss of connection. A communication network that begins to break down. Signals either slow down or get entirely lost. The synapses become weak and start to disappear. And then there's another picture I have over here that shows the amyloid plaques. You can see that the amyloid plaques are being deposited on the axon, and they can also be deposited towards the axon terminals. Those areas where amyloid plaques are being deposited can interfere with a normal communication between neurons, which, for example, if you see this picture over here, you could see if an amyloid plaque gets deposited over here or over here, it'll inhibit or defect a communication signal between two neurons. So as this damage worsens, the brain's ability to send and receive messages is affected, leading to symptoms like memory loss, confusion, and difficulty thinking clearly. So while healthy neurons communicate efficiently through strong synapses, Alzheimer's disrupts this pathway, causing a breakdown in brain's messaging system. So here, what exactly does amyloid plaques do to the brain? So like I mentioned before, because of their presence of deposit on the neuron, the abnormal levels of these proteins cause block in cell-to-cell signaling at synapses, which is essential for storing memories, processing thoughts and emotions, and planning. So this slide will introduce remternetug, the investigational product used in DIAN-2002 primary prevention study. This drug is being studied as a potential treatment for Alzheimer's disease. This drug is given as a subcutaneous injection, which is an injection administered just under the skin at a dose of 400 milligrams. I'll go more into detail about the subcutaneous administration and how it looks like in a couple of slides, so we'll revisit this slide shortly. So understanding the why and how a drug works is crucial for understanding its potential in slowing disease progression. Remternetug is a monoclonal antibody designed specifically to target amyloid plaques, which are one of the hallmark features of Alzheimer's disease. As I mentioned previously, these plaques are toxic protein that build up and interfere with neuron communication in the brain. So here I'm going to show you about how I've already went through what remternetug is and what amyloid plaques is. But the question is, how are they connected, right? So in people with Alzheimer's disease, amyloid plaque builds up in the brain, harming brain cells. So this drug, how does this drug work? So this drug works by binding to amyloid beta plaques in the brain and helping the body clear them, aiming to reduce or prevent the damage these plaques cause. The drug basically tags the plaque, marking them for clearance. Then the brain immune cells, mainly the microglia, detect the tagged plaques and work to break them down and remove them. This process reduces the amount of amyloid buildup in the brain. So here is another picture. As you can see, you have the healthy neuron, how there's no amyloid plaques deposited. This one is one that already has amyloid plaques in place. So the expected clinical effects of this, of using remternetug is by clearing amyloid plaques, remternetug aims to slow the progression of Alzheimer's symptoms such as memory loss, confusion, and cognitive decline. However, it is important to note that while amyloid removal may slow disease progression, it does not cure the disease or fully reverse damage that's already done. So for anyone that's sensitive to medical images, especially needles, I just want to give you a heads up that there will be some that'll appear on the next slide. So please feel free to look away if that makes you feel any comfortable, okay? Okay, so now let's take a moment to walk through the administration format for this drug in this study. It is administered subcutaneously in the study. It is a method designed to deliver medication between the layers of the skin, just beneath the skin, between the subcutaneous and the muscle. It's going to be right over here where the needle is being inserted. The needle used for this injection would be around 4 to 6 millimeters in length, which makes the injection relatively low in discomfort and quick to perform. So a lot of people often like to know where it's coming from or how does the drug looks like. So when we receive it from pharmacy, this is how it's going to look like. This is the injection that we will be receiving, and this is the cap. And when we remove it, you'll have this needle over here, which is what we will be administering in a 45-degree angle. There are 3 primary injection sites where this drug can be administered. It would be the abdomen, which is the most common site, the thighs, and the upper arms. It is important, however, to rotate injection sites to reduce the risk of skin irritation. So now we'll take a closer look at what a typical clinical visit might look like, specifically one that doesn't involve any cognitive assessment or imaging. So these types of visits take place quarterly and are focused on dose administration and on monitoring overall health, treatment tolerance, and any side effects. Therefore, they're more quicker and straightforward in comparison to an evaluation-based visit. So upon arrival, you'll be greeted by one of the members of the team. The participant is asked how they've been feeling since the last visit. This includes any side effects they might be experiencing, changes in mood, sleep, appetite, or just general well-being. We'll confirm with the participant that there has not been any changes in medication or changes in like they stopped taking a medication or they've started on a new medication or supplement. Vital signs will be collected prior to dosing. Blood samples may be collected depending on the visit. So not all visits require blood collection. So there are visits where we might need to take blood collection. And monitor, and these, like Tina had already mentioned, blood collection are usually used to monitor routine safety labs and to make sure biomarkers related to the treatment. Then we have the subcutaneous injection that will be administered, followed by post-dose monitoring. And finally, the participant has time to ask for questions, raise any concern, and confirm the timing for their next visit. Within 24 hours of the dose administration, a nurse will either contact you via phone or email for a follow-up regarding how things went. So as with any medical treatment, it is important to have a clear understanding of potential risks involved. So risk doesn't mean harm will occur, but it does mean that we need to monitor carefully, have open communication, and act quickly if any symptoms do arise. So when we talk about the risk of remternetug, we're referring to the known side effects observed during clinical trials and possible reactions that may occur with this type of therapy. So as per the data retrieved from March 2024, the common symptoms include like other anti-amyloid monoclonal antibodies, the remternetug can carry risks such as brain swelling or small bleeds called amyloid-related imaging abnormalities, so ARIA, which often need monitoring by MRI. These are changes seen on the brain MRI scans, which may or may not be symptoms, may not cause symptoms. There are two types. So there's one that's called ARIA-E, which is a swelling in the brain, and then there's ARIA-H, which refer to the small bleeds. Other risks include headache, dizziness, redness of the skin at the injection site, or injection site reaction, as well as allergic reaction. When it comes to allergic reaction, it comes down to rashes, fever, shortness of breath, hives, which are like raised red spots on the skin, and itchiness. So far, as per the data, no serious allergic reactions have been observed. So in terms of, like I said, there are ways in how the study monitors or mitigates this risk. So those include, there's presence of safety protocols in place, including regular check-ins and scans between dosing that ensure that any risks identified are managed early. So ongoing monitoring that are required while a participant is on this drug include safety scans, so MRI and PET scans, biomarkers. A trained professional administers the dose at site. There's always post-dose monitoring, so this allows for any reaction to be assessed before the participant leaves. Emergency medications are within reach and available at site in case there is a reaction. Follow-ups and routine check-ins by staff and principal investigators, as well as physical and neurological exams, pregnancy testing for those who fall in this category, and suicidality questionnaires to assess your mood throughout the day and the study. Other safety tests include electrocardiogram, which is ECG. It is to monitor the heart health and vital signs. So all these components work together to ensure that treatment is both safe and effective over time. So finally, I want to thank each of you who've logged in today to learn more about this trial. Whether you're a caregiver, a clinician, or someone personally impacted by Alzheimer's disease, your involvement is what helps move research forward. And once again, a big thank you to Toronto Dementia Research Alliance for offering this valuable platform to share and connect. So to wrap up, we want to make sure you feel supported and informed every step of the way. If you have any questions about the study, the investigational product, monitoring operations, procedures, or your participation, please don't hesitate to reach out. The study information, like mentioned before, is also included on the TDN website for people to read about the brief description that's offered about the study. So whether you can also contact myself or Tina, as well as the principal investigator of this study, Dr. Mario Masellis. He's also here joining us in this webinar. And it will take place at the Sunnybrook Health Sciences Center. So whether it's a quick question or something more detailed, we're always here to help you guide through the process. Thank you.